Hello everyone, we are happy to share our preliminary results about the neuromodulation for drug-resistant epilepsy by low-intensity focused ultrasound. This study was sponsored by FUS. The team members had no other conflict of interest related to this study. Low-intensity focused ultrasound have a neuromodulation effect of animals and humans' brain. In animals, the FUS showed EEG changes in the acute seizure model. However, the safety and effect of FUS on humans with epilepsy have not been well established. Patients who have finished their intracranial EEG studies could provide an opportunity to investigate the safety and the effect of FUS. The IEG recording during FUS also provide real-time neurophysiology information. We screened patients who finished their SEEG studies. The seizure onset electrode was chosen to be the target of FUS. The technician will examine if the target and the bone condition suitable for FUS treatment. We exclude patients with implanted device, wound infection on scalp, recent major psychiatric event, pregnancy, and the implanted object with metals in the FUS exposure pathway. Not like the other focused ultrasound system guided by MRI, we use FUS, which is guided by a navigator system. The target and the trajectory are shown on the screen. The neurosurgeon holds the transducer and adjusts the position to fit the pre-planned pathway. On the day of treatment, we shave patient's hair and register the navigator system. The parameter was according to our previous animal study. The FUS treatment lasted for 10 minutes. During this period, the patient was asked not to move. 6 patients completed the study. The clinical characteristics were summarized in this table. Habitual seizure recurred after FUS, ranging from hours to months. There was no long-time remission anyway. Among the 6 cases, 1 complained of heat sensation over the transducer contact scalp. We stopped and waited for 1 hour. In the second trial, the patient tolerated well and completed the 10 minutes treatment. 3 cases complained of localized pain over treatment area, and we thought it is related to the small shaving wounds. For case 5, naming and memory impairment developed on the day after SEEG removal. There was no focal weakness or sensory impairments, no intracranial hemorrhage or infarction. The EEG showed no non-convulsive seizures or encephalopathy. The deficit was conditional and inconsistent. We speculated it was a functional neurologic disorder. The symptom resolved in 10 days. This is her seizure frequency over time. The symptom occurred after a 3-day seizure reduction period. It was like the phenomenon of false normalization when seizures are greatly reduced after intervention. In our case, no lesioning effect could be noted related to FUS. There were 3 cases with seizures in the baseline and the observation periods. The seizures in case 2 were subclinical. For case 5 and 6, the habitual clinical seizure reduced after treatment. We counted the interictal epileptic bone discharge on target electrode. There was no consistent pattern of number changes after FUS treatment. We analyzed the power changing of the target electrode during and after FUS. There was a trend of increased power during sonication and reduced power after treatment compared to the baseline. In case 2, we have 2 data sets. The treatment duration of the first trial was 260 seconds, and the second trial was 600 seconds. The power changes during and after sonication was significantly greater when the treatment duration increased. Our conclusion is that focused ultrasound is safe and feasible in neuromodulation of a target region for drug-resistant epilepsy. Simultaneous IEG recording show power changes during and after treatment. More cases and different sonication protocols are necessary to determine the significance of IEG changes and future application in clinical practice. Thank you very much.